Hello, everyone. Good evening, and welcome to yet another episode of ICPA Clinical Series. And as you all know, the theme of ICPA Clinical Series is each episode one clinical challenge. And today is the 20th episode and last episode of this year. And today we have one of the luminaries, one of the very well known personalities in the field of periodontics and implantology, as well as dentistry in India and abroad. Dr. Sudhindra Kulkarni, my very dear friend, and who is known for his excellent implantology cases and presentations, one of the pioneers in the field of implantology in India, who started implantology when there was very little evidence. So he comes among those people who built evidence over the years, and we have learned a lot from his presentations and his case documentations, and he has so much of original data, not only in implantology but also from his main field, that is periodontics. And when we discussed about this episode, he said he has got certain ideas about periodontics that he would like to share with everybody. So we agreed upon this topic: contemporary periodontal practice, monetizing regenerative periodontal surgery in current day practice scenario. So it's an exciting topic, and we are all going to hear from the right person. Let me tell his bio in short to all of you. Dr. Sudhindra is a periodontist by training and passion, and he practices in Hubli. He is a fellow of Indian Society of Oral Implantologists, diplomate of ICOI, and recently has become the editor of Journal of Dental Implants of ISOI. Formerly, he was the professor and head Department of Implantology in SDM Dental College, Dharwad, and currently he is the consultant and professor of periodontics and implantology at PMNM Dental College, Bagalkot. So, without wasting much time, now I invite Sudhindra on screen and I request him to start with his presentation. Sudhindra, the show is yours now.
Good evening, everyone, and thanks, Rajiv. Am I audible? Can you just give me
Yeah,
this one?
yeah.
Okay, great. Thank you. Very good evening to one and all. Though COVID is gone, but I still love this forum of online webinars for the reason that you don't have to move out from the comfort of your house at times. Though we miss meeting friends in person, but I think there are times when these kind of webinars still make sense uh, to reach to a much wider crowd. So thank you, Raji, for hosting this, and thanks to ICPA for this wonderful series of webinars that you've been conducting over the last year. And though it's probably the last one for this year, I'm pretty sure it's probably one of those which I think would make everyone think twice before extracting that tooth, which probably can be saved by intervening in the right approach. Just a little bit about what we call as periodontics and regenerative periodontal therapy. I always say this: everything in dentistry depends upon the top 3 millimeters. It's 3 millimeters of free gingiva around a natural tooth, minimum 3 millimeters of bone holding the tooth, minimum 3 of bone surrounding the implant, and that's what is important. And we'll come to this picture as we conclude our today's presentation. Okay. So without much of this one, let's look at today's agenda, what we intend to cover. Let's look at what are the effects of periodontal disease. Let's look at how are we managing periodontal disease as of today. Then we come to regenerative periodontal therapy. When I'm looking at regenerative periodontal therapy, I'm looking at why and when, the indications, when we do regenerative approaches, how, that is, what are the various procedures to regenerate periodontal tissues, and then what's more important is why and when is more important, but what's important from a patient perspective, what's important from a clinician's perspective or from the outcomes. And let's see what happens when you do a regenerative periodontal surgery. Coming to a very simple definition, let's understand because
Sudhindra,
this is a more of a clinical
Sudhindra, your
based
slides are not moving.
topic. And
Sudhindra, your
hello,
slides are not moving. You have to put the presentation mode.
one second. It's not moving now.
moving, but they are not in the presentation mode.
Can you see this?
What is periodices? That
No,
slide
they
we can
are. No,
put it
wait.
in the,
I've come to the first slide again.
yeah, yeah, first slide again, but put it in the play mode. Full screen. It is not full screen,
Yeah,
but
it's in the play mode only. Hold on. Wait 1 second. Wait. Raju, what I have here is a full screen only. Actually, I'll just send it to your WhatsApp here. It's actually on a full screen mode only.
actually we are able to see the. No, it's okay. You continue. Continue.
See,
No problem.
I'm 1 second. I think sometimes on the Mac this happens with the double screening. One
Yeah.
second. Just 1 second. One second. I don't know why is this happening. It should come window. Just had everything going right.
No, it's okay. It's okay.
Yes. Now?
It's coming. It's just a minute.
Yeah,
Yeah, now
one
make it
second.
clear.
Here you come. 1 second. Just now?
Yeah, now perfect. Go ahead.
Okay, thank you. Yeah, sorry for the glitch. So the agenda will be, let's look at effects of periodontal disease, management of periodontal diseases, regenerative periodontal, that's today's topic, why, when, and how, and the outcomes. Because today we are probably speaking primarily on a clinical basis, I'm not looking at literature. I'm not looking at quoting literature on what is the percentage of gain or whatever. I'm literally looking at those terms which make difference to me as a clinician and to my patient who's paying me the money to treat his teeth. Okay. So let's look at in a very simplest form what's a periodontal disease. Periodontal disease is nothing but inflammation of supporting structures of the tooth. That's gingiva. That's what is the only thing that's clinically visible. But when this inflammatory process goes deeper down, crosses the junctional epithelium and then goes deeper down, what it does is it leads to loss of periodontal ligament fiber attachment. It leads to crestal bone loss, and it also leads to what we call exposure of the cementum to the oral cavity. And the cementum that gets exposed to the oral cavity will eventually either get washed out, or because it's very, very thin, it just gets worn out in a day-to-day process. And as the disease progresses, we'll either see mobility of the tooth, we'll see pockets, we'll see recession, or we'll probably see a combination of all three. So you can have a tooth which has got pocket, it's got a recession, and also mobility. Along with that, we'll see all the gingival findings of change in color, contour, etc., everything that we all have learned. We all know that the etiology of all types of periodontal disease is primarily dental plaque and related products. There's a major section of periodontal disease that's iatrogenic. We all know that patients come to us for caries, proximal caries, etc. And most of the time, a lot of time rather, these restorations are not well done. And we see a lot of interdental bone loss secondary to improper dentistry that's been done. So iatrogenic periodontal disease is something I would actually put much higher above most of the other causes of periodontal disease that I see in my clinic. Apart from that, yes, periodontal disease can be modified by systemic conditions. That's not the part of our this one today. Let's look at what are we seeing when a patient walks into our clinic. Most of the patients who walk into our clinic with or whom we would call as patients with periodontal disease would either complain of bleeding gums or a bad odor. That would be the most common complaint by which they come to the clinic. Apart from that, you will also hear them telling that, doc, I have food getting stuck between my teeth, which directly or indirectly indicates as a pocket. They would usually tell, doctor, I have a dull noise sensation. I feel there is something like a toothpick. I need to feel like I'm digging it out. That's a very classical sensation. On the other hand, patients who have periodontal disease but don't give this symptom, they usually end up giving you the other spectrum of symptoms that we call as tooth sensitivity. That directly relates to gingival recession, Or they may even tell, doctor, my teeth were so nice and neat. Suddenly I feel that my gums have gone away, my gums have got thinned, and I see that my teeth are looking longer than what they were before. So these are the various classical signs with which a patient walks into our clinic. Apart from that, obviously, is tooth mobility. Uh, in my personal experience, I've seen that when the day the patient actually tells the tooth is mobile or he's walked into the clinic due to tooth mobility is probably the time the tooth has to be removed or whatever. Because in all likelihood, by the time they come with a certain degree of mobility or when they complain of mobility, it's usually a grade 3 mobile tooth. Next, coming to therapeutic approaches, we all know there are gingival diseases and periodontal diseases. In my opinion, gingival diseases should be completely treated by general practitioners. There's actually no role of a periodontist in treating these conditions. Okay, what do I mean by gingival disease? Any disease that is restricted to not going beyond the what you call the junctional epithelial attachment. You see signs of inflammation. There's a lot of plaque, calculus, etc. These all should be treated by what we call as general practitioners. Okay, and if at this particular point in time, even after doing probably 2 3 rounds of proper supragingival and a little bit of subgingival instrumentation also, the gingival conditions have not improved, the tooth mobility has not reduced, or patient is still not feeling good, or you see active exudation, and then that's a time or that's a point where the case is fit to be referred to a specialist periodontist, and then because most of these cases then would fall into the category of periodontal diseases. Okay, I would say that for a general practitioner, if you identify these conditions, you can do the phase 1, but then you are better off referring the patient to a periodontist for better treatment approaches. This is what I call as a blessing of a case. It means when patient walks in and you see a condition like this is what I call as a clinically healthy situation. What do we mean by this? You'll see that the gingiva is pink. You can have melanosis, you can have melanic pigmentation, but it's pink. You will see that there is nice stippling everywhere around. There is no sign of bulbousness of the interdental papilla. You may have stains. Patients may have stains, but as long as the gingiva is not inflamed, it means that it's a very clinically healthy condition that we are seeing in our patient's mouth. Okay. Now, when plaque starts accumulating on these conditions, when a patient is clinically healthy and for some reason the oral hygiene goes for a toss, that's when we start seeing signs of gingival inflammation. And depending upon the amount of calculus, the amount of plaque, how poor the oral hygiene is of your patient, you will start seeing signs of inflammation. And these are what we call as plaque and calculus-induced gingival diseases or periodontal diseases. Okay, you will see the gingiva becoming red, bulbous. You can see exudation there on the 2-1, 2-1-1. You will see gingival recession. You will see gingiva in forms which is not native. Okay, and probably at times you can take a probe or you can even just touch the area with your finger, the area starts bleeding. And this is a very classical sign of what we call as gingival and periodontal diseases. On the other hand, this is one category of diseases where you actually do not see any inflammation at all. You look at this photograph, you'll see what can be wrong. There's a bit of recession on those laterals, but what can be wrong? You can't find anything here. The gingiva looks absolutely healthy. There's no sign of inflammation. But when you take a probe and insert it into the gingiva of these patients, you'll start seeing pockets. You'll see that the probe is literally going down to 8 to 10 millimeters in all these areas. And that's why the diagnosis or differentiation on a clinical basis between gingival and periodontal disease is not just about clinical appearance of the gingiva, but probing becomes a very important part of identifying periodontal disease. Okay, and when we use the word probing, it's literally like a CBI probe, okay, or a ED probe. It means that you're actually taking a tool and trying to dig out what can be wrong in which area. Okay, and for everyone, we all know that the two most commonly used probes would be a University of North Carolina 15 millimeter long probe or a University of Michigan probe with William marking, or commonly known as a perio probe or a Williams probe. These probes have nearly a uniform diameter, they have a rounded tip, and they have markings. And depending upon how deep the probe has gone in, That would literally tell you whether your patient has got a pocket, whether it's got a recession or a combination of both. So apart from seeing the patient clinically for signs of inflammation, we are looking at what we call as whether there is presence of pockets. Apart from that, you also look for tooth mobility in all these cases. Once you identified any patient for gingival or periodontal disease, the most important step in everything is the first phase of treatment, or what we call as the non-surgical periodontal therapy, or also known as NSPT. Okay, a patient walks in with clinical signs and symptoms like this, with gingival inflammation, there is some recession, lot of calculus and plaque. Okay, so what you do is you do your phase one therapy, that is the first phase of scaling and root planing, and then you evaluate. You wait for a week, you will start seeing that the gingivas become much better. Most of the calculus and plaque, which is clinically visible on day one, has been taken out. And that's why the plaque and calculus, which are subgingival now, has become supragingival. You'll also notice your patients will complain when they come back to you at the end of 1 week after the first phase of non-surgical therapy or scaling. When you will see that they will complain of gaps opening in those areas which never existed. They'll also tell, doctor, my gums are gone away. You had told my gums will become healthy. Now you see that my tooth is appearing more longer than what it was before. You'll also see these patients complaining, doctor, I see that my teeth have become mobile. I feel air going between the teeth. I have sensitivity and everything else. Yes, that's why I always say, when you take up or once you diagnose a patient with periodontal disease, when you take them for intervention, these are the things you have to tell them up front. Okay, before you take that scaler and do a first round of scaling, you need to tell them, after the scaling has been done, this is what you're going to feel. You'll feel that your gums are shrinking, you feel gaps opening between your teeth, you may feel a bit of increase in mobility, you may feel a bit of sensitivity. So you need to educate the patient upfront about what he or she may anticipate when the phase one of treatment is over, or even one sitting of treatment is over. You do the next sitting of scaling now, and then probably at the end of 2 weeks, you would start noticing something like this. Okay, now the gingivas become far more healthier. It still is showing signs of bleeding, etc., but it looks far more better than what it was before. And then now you know that if there is no further pocketing, etc., this patient can be on maintenance phase or a routine follow-up. That's what a non-surgical phase of treatment would require. But yes, what will be the most important criteria here is you take a probe, again check for pockets, and then refer the patient for intervention if required. If not, then you are the best judge for the patient when he or she should come back to you for intervention. Coming to the most important part of today's, once you've done all your non-surgical therapy, I'm a very firm believer in non-surgical periodontal therapy, because when you do non-surgical periodontal therapy, the interventions are minimal. There is no surgical, there is no local anesthesia, post-op morbidity is zero, and patients feel comfortable. And you can call the patient 2 times, 3 times, 4 times, and you can keep on doing it, and they'll also feel good because there is no surgical work involved. However, there is a category of patients in whom, even after doing multiple rounds of non-surgical therapy, whether it is hand instrumentation, ultrasonic instrumentation, laser, and everything else under the sun, okay, even after doing everything, the pockets do not resolve. There is still some exudation, there is some gingival bleeding, and these are those cases which then would come into the category of those cases requiring surgery. Every case of periodontal disease which would not, or which does not respond to non-surgical therapy the way we want it to respond, is a case for surgical approach. And when you do a surgical approach, it is always a regenerative surgery. I, as a principle, never open a flap and close it back. Okay? Because if I'm opening a flap and closing it back, it's always along with a regenerative approach. Because if I'm opening a flap and closing it back only, then it means that I have all horizontal patterns of bone loss, and I think I can deal with all of those defects in a non-surgical manner. Whereas if I have angular bone defects, if I have one wall defect or a two wall or a crater, or those defects where my regular instruments would not go deeper down and clean up, then I would do a surgery. And then every time I open a flap, it means that there is a bone graft and there's a membrane or any other active regenerative material like a PRF or like an emdogain going in. So I would not look at doing any surgery without a regenerative approach. Why regenerative surgery? Just let's look at this case. This was done by my boss. Okay, this was done by my mentor, Dr. Vijay Chava. Okay, this was done in the year 2006. The patient was treated in, she was a very young 23, 24-year-old female patient, then aggressive form of periodontal disease. This is the year 2006 when this girl was treated. Okay, you can see angular bone loss in relation to 1.6, 1.1, 2.1, 1.2, 2.4, 2.5, 3.6, 3.5, the lower incisors, the lower premolars. Literally every tooth had an angular pattern of bone loss. Okay, this patient was treated with 3 rounds of non-surgical and then 2 rounds of surgery with what you call a GTR and a bone graft. Okay, the graft material used then was Geislich, small granules, and then along with that, patient also was put through using what you call bioguide membrane in every defect. Every defect got a bone graft, and every defect got a membrane. And you will see this is 2015 when I saw this lady last. Okay, because after he operated, he left, and then so I was doing the follow up for this patient. And in 2015, when I saw her last, you can see every tooth in the mouth. That's 9 years down the line. Every tooth in the mouth with so much of bone loss is still present. Every tooth has been absolutely functional, and you will see that most of the defects have healed up. And that's what tells us when a regenerative approach has been done the right way, it will respond. And what it does when it responds to see that the tooth lasts in the mouth for a much longer period of time. And that's what we want. We want the natural teeth to stay in our patient's mouth for a much, much longer period of time than taking it out and putting an implant. I wouldn't want to do an implant in a 23-year-old girl. I would rather do it in a 35-year-old girl for a very simple reason that we all know that when we treat natural teeth, they last. A tooth with 50%, I always say this, a tooth with 50% bone would last much longer than an implant with 50% bone. So let's look at it. So I would rather go out and do regenerative surgery on all my patients where I can do it rather than taking them out and putting an implant. So going by the book definition, I would say what is regeneration? It's a restitution or reconstitution of lost parts of structures of the body by cells or tissues belonging to the same type. In simple words, replace the missing tissues with identical tissues. So if you lost gingiva, replace gingiva. If you lost cementum, you should get cementum. If you lost bone, you should get bone. Everything should come back. Now, coming to why do we have to do periodontal regenerative surgeries? Because every time there is a disease process, there is hard and soft tissue loss. And the goal of every treatment is to replace these lost tissue. I want to replace the tissue that's been lost, and that's why I want to do it. Fill the defect and restore the form and function. Let's just skip this. Next is the most important question from a clinical perspective, from how much time I'm going to spend on patients. After spending all this effort on putting a graft, membrane, cost of treatment, intervention, etc., can you regenerate? Yes, we can regenerate. The next question is it 100%? No, you cannot regenerate 100% of the periodontal tissues that have been lost. But yes, I can easily regenerate 50%. Okay, even with a decently done periodontal surgery with the regenerative materials, you can generate 50%. And with this 50%, a tooth would last much longer than an implant with 50% bone. So you have to understand that. Okay, so save the tooth. Next, we come to when I do it. I will do it in localized defects. You do it in a containing defect. Any defect where a graft can stay, you'll treat that. Okay, you need to have good soft tissue, and obviously the tooth has to be stable. And what do I mean by tooth has to be stable? It means that the tooth should be grade 2, within a grade 1 and grade 2 mobility, and it should be splintable. Contraindication should be a generalized horizontal pattern of bone loss, which can be treated with non-surgical, or teeth which are grade 3 mobile. So these are pure contraindications for any regenerative surgery. You don't want to do periodontics here. Expected clinical outcomes. From a patient point of view, what are the outcomes? Tooth is still in the mouth. So if I do a surgery in 2022 and I see the patient back in 2028 and the tooth is still in the mouth, yes, it's a measurable outcome. Patient can understand that the tooth is there. It was worth undergoing this treatment. The tooth should be asymptomatic, obviously, and it should be functional. So every tooth that you've treated should be functional and asymptomatic. From a clinical or clinician's perspective, what I can measure, that there is a reduction in closing pocket depth, there is no exudation, and there's obviously no increase in the tooth mobility. If these are the parameters that you can see in the patient's mouth, it means you've been successful with your regenerative periodontal surgery. Just a chart on what we want. I will probably be just skipping through. To achieve a proper regeneration, we need cells, scaffolds, and signaling molecules, and something called as a time, space, and bacteria-free environment. That's when you get a regeneration. Uh, let's come to this. Periodontal regeneration is tougher. It's tougher than vertical bone augmentation. Ask me, I'll tell you that. Okay, I can augment a bone 10 millimeters vertical, but generating 5 millimeters vertical bone in a period defect is far tougher. And the very reason for that is this: getting a time, space, and bacteria-free environment, even after using the best of the graft, the best of the membranes, everything, getting a bacteria-free environment around a natural tooth is very tough. When I'm doing a ridge augmentation, when I seal it off completely and achieve a primary closure, it's a sealed environment. Whereas around a natural tooth, that doesn't happen. And that's why it is not possible. It's not possible to get 100% periodontal regeneration. You can get 50%, and that 50% is more than sufficient. Next, we come to what all we will be doing in a regenerative therapy. It includes flap management. Now, earlier, when me and Rajiv and all of us were studying, we were told to do a full flap, open a flap here to there, clean it up, and then close it back. Now we are looking at very minimal flaps, small flaps. Root surface modification. You have to clean the root, okay? And you see that it doesn't have any active calculus lying on the surface. You will always, every time you look at regenerative, you want a GTR membrane, and then obviously bone graft materials. So let's see all these factors in detail one by one. Okay. Root surface biomodification, you have to remove all the visible debris. There is a huge, what is called debate on whether you want to treat the surface with citric acid, tetracycline, EDTA, enamel matrix. So there are multiple sources by which you can modify the root surface. At the end of the day, what I want to achieve is when I see the root surface, it should be clean. That's number one. Second is I should have an area where I can use some active agents, and primarily the most active agent what I want to use would be an enamel matrix protein on the root surface. Okay, so when I clean it, I clean the surface, I remove all the bacteria, all the toxins on the root, and that's what I want. The next is bone graft. Is bone graft a must for periodontal regeneration? Let's look at it in this manner. The role of the graft in perio regeneration is primarily to support the membrane and also to hold the flap up. Okay, you may not have bone, but as long as you have fibers running from the bone into the cemental surface, you will have regeneration. But the issue is why I need a bone graft. I want to fill the defect. If I have a ditch, I want to put some material that will cover the defect and then create a ridge form, and that's why I need a bone graft. You have all the grafts available under the sun, and probably most of them would work in a perio defect. It's not necessary that you should always use an autogenous graft, or a non-bone graft will not work. Most of the grafts work very well in a perio defect because most of these are self-contained defects, and that's why all the grafts will do well. Most important factor when it comes to regenerative periodontal surgery is use of a GTR membrane. Okay, you cannot do a regenerative surgery without a GTR membrane. There is only one place where you can do it. I'll come to that as we conclude our presentation. Till that time, consider that without a GTR membrane, you cannot achieve periodontal regeneration. And what does a GTR membrane do? You can see here in the picture. It is something called a selective cell population. Okay, it cuts out the gingival tissue from the red clot area, what you see there. Being there, it stabilizes the clot. So the clot does not move, it becomes stable, and that's once you have a good clot, you have all the growth factors necessary for a regeneration. That's what the membrane does. Obviously, prevention of epithelial down migration. When we were studying, this was probably the first thing that was sold to us. Okay, not just told, it was also sold. You put a membrane, you tie it around, the epithelial cell will not grow between the membrane and the root surface. That's what we are told. Okay, let's understand the epithelial cell is so tiny that it can go in between the membrane and the root surface. Okay, so think of this epithelial down migration prevention as probably a bogey. Okay. Also, you can use the GTR membranes if you impregnate with PRF or any other growth factor materials. Obviously, it will help in carrying those to the area. So you will require a GTR membrane to get regenerative periodontal therapy. Okay, let's just keep this out. Different membranes are available, resorbable, non-resorbable, but most of my surgical procedures, what I have personally done to achieve regeneration of periodontal tissues has been always with a collagen membrane, has always been with a resorbable collagen membrane. Okay, you can see all the brands available there. I probably use all of them. Okay, but yes, I always have used a resorbable collagen membrane for perio regeneration. We probably use so many others for bone augmentation, but when it comes to perio regeneration, I've just used collagen and nothing else. Okay. Also, you can enrich your operating site with growth factors, cells, and proteins. So we'll come to this a bit later. Okay. Uh, this is one product. It was the year 99. It was a Journal of Clinical Periodontology. I was doing my post graduation, and there was a special issue that came in that year. Okay. There's probably a series of 6 articles that came in, led by Hammarstrom et al., if I got his name right. Okay. And now, what did we see there? He came up with this miraculous material. What they claim to be miraculous is amylogenin. Uh, this is the same protein that's released by the Hertwig's epithelial root sheath, we all know. And the release of this would stimulate or initiate the formation of the root. So the concept is when you use this material on the root surface, it will help in taking the clock back. So you have a root surface, you clean it, you put this material, and it will turn the clock back and stimulate formation of acellular extrinsic fiber cementum on the root surface. And once AEFC forms, that's when the PDL fibers will attach, and that's how you get a periodontal regeneration. Okay, so this was in 1999. We never had access to this material till 2 years back when Straumann India launched this in India, and I've been using it now for the last 2 years. And let me tell you, I've been pretty happy with the way it's worked. Okay, so let's see some work a bit later down the line. Clamp management, we'll see as we go further. So as a patient walks into my clinic, what I'm looking at when I'm planning a regenerative, it is cleanup phase and SRP and follow-up. That would probably be a 9-month protocol. I never do a regenerative surgery in anyone who's below 9 months into my surgery. Okay, so I do a cleanup, phase one, follow-up, again a cleanup at 3 months, again a cleanup at 3 months, and after 9 months of this initial intervention, please understand 9 months from the day I have diagnosed and ready the treatment plan, it's only after 9 months, that's when, after doing everything else, if the pockets are not resolving, that's when I take them up for surgery. Okay, and what do I mean by monetization? So every time patient comes to the clinic for an intervention, he's paying the bill, he's paying treatment charges, and that's why it is monetizing. Okay, then obviously you evaluate, you select the areas where you want. One of the most important things that is usually neglected is selection of the case and selection of the site. Okay, you don't, just because you have a gun, you don't keep on shooting everywhere, isn't it? In exactly similar manner, just because you have graft material and a membrane lying with you, you don't go and put it in every site. There are sites where a certain treatment will work, there are sites where a certain treatment would not work. So you need to pick and choose where you want to do what, and that's where site selection comes into picture. Obviously, then you select the appropriate material, and then one of the most important thing is patient education and motivation for all these procedures. That goes without saying. Let's look at this case. This is a patient whom I treated in the year 2007. This is how he came into the clinic. Well, you can see there the angular bone loss in every tooth. There is furcation involvement with the upper sixes, lower sixes. Upper anteriors are literally lost more than 50% of the bone. two six is nearly gone. Okay, lower anteriors are gone. Okay, so this is how he walked in. He had undergone 2 rounds of non-surgical therapy before he came into the clinic. The lower incisors couldn't be saved, but as we opened up the posterior areas, you can see the patterns of bone loss there, buccally as well as palatally. All these defects were grafted. You can see the lingual furcation on the forceps there, grafted, membraned out, and closed. The teeth which could not be saved were taken out, implants were done, restorative work was done, and that's how he looked probably at the end of 6 months after the phase 1 of surgical therapy was done and everything else on both the right and left sides. Okay. This is at the end of 2 years post surgery. Clinically, that's how it looks, and this is at the end of 5 years of post surgery. Okay, let's look at the radiograph when I saw him. This is 2 years on the posterior side. You can see how the tissue is. There is no loss of tissue in the interproximal areas. There is no guttering. There is no ditch because all the defects were grafted with the graft and membrane. That's at the end of 5 years. You can see how beautiful, and every tooth has been there in the mouth. No tooth has ever been extracted. And you can see here on the radiograph, this is at the end of 2 years follow-up on this case. Every arrow that you can see there, you can see the defect and what has been the outcome. You can see with 3/6, the furcation involvement is gone. The distal of 3/6, the bone is filled. The 4/6, the angular bone defect is completely filled up. The furcation of 4/6 is gone. 1/6 mesial defect and distal defects are completely healed up. And you can see all the upper anteriors are absolutely rock solid stable. There's no, this is splintered, and that probably aided in getting a much better bone formation around those teeth. Let's look at 5 years on the same case. It looks as fabulous as it can be. And what this shows is when a certain procedure is done the right way, it will hold up, and that's what we want. We want the procedures to be successful, and we were retaining the teeth in the mouth. Okay. Now, someone could question me on why so much of surgical work, graft, and everything. Why not just take out and put implants everywhere? Again, go back to the point to tell. This was probably a 35-year-old man when I treated. Now, even today, he comes for follow-up. I don't have his recent X-ray, but all his teeth, he's exactly the same position the way he is today. This is now literally a 15-year follow-up. What I can tell him is not lost any tooth. So that tells you natural teeth, even 50% bone, will last longer than an implant which has lost just 2 millimeters of bone. Please understand that. Let's look at one more case from a very clinical perspective. This is something you can do here in your clinics. This is a probing for a 3/6 mesial. It's a 10 millimeter pocket there. You can see the kind of angular bone defect. You understand every time you graft only till the existing bone level that you see there. Okay, clean up, put the graft material. Okay, don't overfill it. Any graft that's overfilled flows out. It's of no use. It creates avascular areas. You fill only till the crest of the bone. Put a membrane, always put a membrane, and the membrane should cover the graft completely. One of the things that we used to do as postgraduates was be very conservative with our flaps when it comes to reflection. Okay, I always say now, if you want to get a good primary closure, go ahead and release your flap well. Open the flap well, release it well so that you can get a good primary closure. Okay, unless you have a good primary closure, the thing of time, space, and bacteria-free environment doesn't come. Let's look at this case done by a student of mine. Wanted to just show an autogenous case. Now this is a canine. You can see here, there's no fun in taking out this tooth. So we opened up the flap, cleaned it up. That's some kind of root conditioning that was being done there. And because we were in the same vicinity, we decided that we would harvest some autogenous bone using the trephine. And the same autogenous bone was packed into the defect. And a nice closure was done with a PRF membrane. Would I use PRF in every situation? Let's understand it's not a panacea for all ills, but yes, because looking at the concentration of growth factors, especially platelet-derived growth factors, yes, it should help us. Also understand a PRF is nothing but a strengthened clot. And what I'm looking at when I'm looking at periodontal regeneration, I need a good clot interface, and that's why a PRF membrane here. Okay. And that's what you would see literally at the end of 6 months of this case follow-up. That was a probing pocket depth in the beginning, and look at the gingival status, so boggy, swollen, etc. And now, whereas post-op, I have what we call around a 4 millimeter residual pocket depth. Yes, there is some recession, but I think the patient and I, both of us, would live with this for the rest of our lives than taking that tooth out. And what you'll see on a radiograph, look at this. This is as beautiful as it can be. Okay, the kind of angular or the vertical bone loss what you had on that tooth, and to the kind of bone that is formed in the grafted area, it looks fabulous. And this tooth will last this patient for a much longer time than probably when I put an implant in that area. Let's look at one more situation. This is a very, very old case of mine, long follow-up. Okay, the maxillary central incisor, dehiscence as well as dehiscence of the labial and an angular defect on the mesial. A conventional GTR membrane shaped up, graft. This is myos then used there, closed. That's how he healed up. And now we did have a recession. The tooth, if you can actually go back and see after the procedure, the tooth actually went back and the diastema between the two teeth reduced. So once you remove the etiology, pathologic migration autocorrects to a large extent. And then we convinced this patient to undergo orthodontics post 1 year after the surgery. So he underwent an orthodontic procedure, and now you can see that that little bit of recession is there, but for that everything is closed up. The patella is filled, and what you can see on a radiograph is this: the angular bone defect, so completely filled defect in this area. That's the CDCT image of this. Some graft probably went on the labial side of the tooth, and you can see here that the root is covered by some granules. I don't promise or I don't vouch for it that it is bone, but what I can tell you is yes, there is something on the labial surface of the root which was not there earlier. And this is at the end of 8 years of follow-up. You can see that little bit of recession on the 2-1 is further covered up, and that shows that post-regenerative surgery, the tooth is absolutely fine. You can even see beautiful stippling. The presence of stippling indicates that your tissues are in the best of their health. Let's look at one more. What do I do with the endoperiolesion lesion? Something like this. Again, literally a 10-12 millimeter defect, a part of the entire larger spectrum of disease in this patient. We opened up. You can see the defect there. A graft filled only till the crest. A PRF membrane going in. That's what does. There's no GTR now. We have a PRF membrane there. We sealed it up. This is at the end of 1 year. How it looks. No interdental tissue loss, and that's how the radiograph looks. Immediate post-op. This is immediate post-op. You can see a lot of those hazy granules there because this was taken immediately after the grafting was done. And this is at the end of 1 year. You can see that all the haziness is gone. The bone is forming pretty well. You can see even in the furcation area, the bone is well. There's a bit of widening, but that looks okay. And you can see the entire defect that was there, distal to the 6, has literally filled up. The crestal bone is undergoing remodeling, and probably that would ossify out a little bit more. And that's how you can see the comparison, immediate post-op to at the end of 1 year of follow-up on this case. Lower incisors, again, given a choice, would you do an implant in this case? Probably no, because my implant will have to sit at a level where you can see where the bone starts. Putting an implant in the lower anterior area at this level would mean that I'm going to give her a tooth this as long as what you can see here on the flap reflected side. Okay, so now what you would look at, you would look at doing regeneration. The lingual wall is intact, so there's no lingual reflection here. It's just a buccal flap that's taken out. Because it was in that area, we could go back, harvest some autogenous. So the same autogenous bone that's been harvested from the parasymphysis has been crushed and placed. Put a lot of PRF there, and then get a nice primary closure. And I saw this lady only when she came for suture removal, and that's how she looked. I'm pretty sure it would have held up. I've not seen her back for follow-up. But when you see this at the end of 15 days, it means that this kind of defect would heal up and hold up much better. Let's look at this. These are those cases which are bad. These are those cases which require much aggressive interventions. Multiple rounds of non-surgical therapy. No clinically detectable inflammation, but 10 to 12 millimeter deep pockets. That's what you would see there. Okay. After 2 rounds of prep, uh, you can see here on the radiograph the kind of defect what this patient had. Let's skip this classification. Yeah, you can see here. Okay, aggressive periodontal disease, but there's a lot of deposits. So I don't say that this only the bacterial induced disease, but probably it's also related to hygiene. You can see the amount of deposits on the root surface on those areas and the kind of bone defects. Each and every speck of the calculus was taken out and then grafted with bone material there. You can see both sides, right and left, upper and lower. Every defect filled to the rest of the bone. Membranes placed on the right and the left side. You can see the defect and closed and sent. This is after 15 days after surgery, how he looked. This at the end of 1 month follow-up, at 8 months follow-up when I saw this patient back. You can see tissues are still settling down. One of the things that you have to appreciate is that the tissue settlement after perio surgery takes a lot of time. At 1 month, you'll see, oh God, what is it? I am not happy with this. But when you see the patient, the same patient at the end of 6 or 8 months, you start seeing tissues are getting much better. You can see here now, in this case, between the 5 and 6, there was a ditch here. Now here, the ditch is gone. Same thing with between 3 and 4 and 4 and 5. Okay. So it's at end of 8 months follow-up. You can see tissues are looking much better. Let's look at the radiograph on this case. I'll just put that, and that will show you the pre-op on top, and that's the 8-month follow-up. You can see here the amount of angular bone defects that you had between 1617, 4647, 1516, then 4546, 353637, 454647, 124. Every tooth had a defect, and each and every defect with graft, you can see here, I put a comparative images. When you start looking at the arrows, you will see that after proper cleaning, intervention, and use of appropriate materials for grafting, we've been able to regenerate bone in each and every defect here, and every tooth, apart from the lateral incisor, has stayed in the mouth and has been stable in the mouth. So that tells you what you can achieve with periodontal surgery. The only thing that would require is a bit of patience on your side as well as for the patient. Let's just look at this small video. Okay, localized defects between 1617. That's how she was after 4 rounds of non-surgical therapy. Gingiva everywhere was fine, but for 3637 and yeah, you can see there distal to 36 and 37. So we went up, opening up a flap. Use a very fine blade. You want to do very minor. When you have localized defects, use a 15C blade to do your incisions. The blade should go deeper down. The blade should go deeper down. Okay. Detach the tissue between the buccal and lingual, far lingual to it. Okay. Don't slice it off right at the buccal line angle, and slowly reflect out your flap. Use a very fine instrument to do that. Now I'm just opening the flap a little bit more, extending it anteriorly and posteriorly so that I get good access to the defect. The other option would be to give a release incision and visualize. You can do both. Okay, but I would always say that you open up and see. Understand, every time you open a flap, you're opening it to get access. And if the access is not proper, then it's futile. So now we clean up. Now you see that defect there, 1 wall defect, distal to the 6. I take, because I had opened up a flap, so I took some bone harvesting drill, harvested some bone. That's endogain now. Okay, enamel matrix protein that's going in from Straumann. So I just connect the nozzle, and after I cleaned up, put up. So now I am applying the endogain enamel matrix protein onto the defect. I'm just filling it there. The question is, the literature says that use of only enamel matrix protein gives you results as similar. The only literature I'm quoting is the results with GTR as well as enamel matrix proteins are comparable. Both give the same result. So you put only enamel matrix protein and you don't put a GTR membrane, that's still good and acceptable. But when I look at it from a clinician's perspective or my personal belief, I don't like to do that. So what I do is I still go ahead, I put an enamel matrix protein as a root conditioning agent, and then I put my graft, I put a membrane, and you see here, this is at the end of 15 days when the patient came for suture removal. This is the same patient on the upper side, just a single papilla, no reflection of the buccal papilla because the defect was only on the palatal side. You can see the defect there. It's being cleaned up, EMD going in. So I treat EMD primarily as a root conditioning agent that would help in forming the what you call as the cellular extrinsic fiber cementum, or out you can even call it here as acellular, what do you call, it can never form acellular afibular cementum, but it can easily form AFC. Okay, so clean the defect. There now I'm just introducing some graft material there. Yeah, that's a graft filled, and then the whole thing gets closed up. That's how it looks at the end of 15 days when the patient came for suture removal. You can see that. Yeah, that's the palatal view. That's the same patient. I'll just jump out these slides. Yeah. Let's look at one more case. This is it's a 45-year-old man who presented with something like this. Maxillary, every other tooth is fine, but for the maxillary canine and the premolar molar, the second quadrant, canine and distal tooth. 3 rounds of NSPT, 3 months apart. Even after that, you start seeing that the gingiva is far better, but there is persistent pocket at the end of this one. So there is a persistent pocketing. This patient had already undergone full mouth flap surgery 6 years back. Okay, and then no regenerative was done. Then it was done elsewhere. So now we go ahead, open up the flap. You can see there's some calculus on that tooth. The kind of defects in both the upper anterior and posterior areas. There's a ledge there, so this ledge has to go. So this patient underwent a bit of resective surgery first. So all the bone that was there in the ledge was taken out. You can see that the bone. Then there is a membrane. That membrane is used to graft up the buccal. I'm not looking at grafting the defect. It is just to fill those small defects so that you get a better tissue outcome and the whole thing gets closed up. Similar, same patient, he had one more defect in relation to 2-1 and 1-1-2-1. Exudation was there previously, so we opened up the flap. You can see the defect there. Suture, graft, membrane, close, and that's how this patient goes. Okay, so I haven't done his suture removal yet, and I'm just waiting for it. So what it goes to show is select the site. I would not do a full mouth flap in this case. You just select the sites and then do your regenerative. The worst patients to do are these young patients, isolated and especially incisive papillary area. Let's look at this case. She was a very young girl, 21 years, I think. Huge pocketing. She had bad exudation there. She had an abscess, if I'm not wrong, when she had presented. After doing non-surgical, there was still exudation, and this is a pocket depth there, buccally and palatally. That's the kind of bone loss that was there between the two teeth. We open up the flap, clean out the defects, and then we use emdogain again. Then use a graft material to fill the defect. If you don't fill the defect in this area, the tissue will collapse, and that's the most disastrous thing to happen. Okay, this is a principle I again follow. If I'm not putting a graft, especially in the anterior maxilla, I will never reflect a flap because the aesthetic disaster that comes subsequently post surgery is unimaginable. So if every time you open up a flap in the anterior maxilla, you have to put a graft and you have to put a membrane. Okay. Now we used a bit of implant related work here. So I did a VIP CT flap. So we harvested the interpositional connective tissue graft, extending that. That's what you see here. That went over the ridge and that got closed. A bit of anatomy there. And that's how we saw her probably at the end of around 15 days. or nearly a month after the procedure. Doesn't look good, isn't it? It just doesn't look good. There is a papilla that's a bit lost. There is some recession there in the incisive area. But yes, the materials work. If your principles have been followed well, everything works well. And this is nearly at the end of 1 year now. You can see here the papilla is coming back. And you'll also see that the tooth, the 2-1, you can see there is a diastema between 1-1 and 2-1. That's gone. The gingival recession on the 2-1 has come down. Okay. And I'm pretty sure we would probably require a bit of orthodontics, and then I think we would be good enough to go on this case. Okay. So when we look at defects in the anterior area, they would always require a regenerative approach. Don't just go open flap debridement. Okay. So with this, I think I'm nearly coming to the time here. Yeah. Let's look at taking the takeaways from this presentation. Number one, is there a place for regenerative periodontal surgery? Yes, absolutely. There is a big role for periodontal regenerative surgery in practice. Second, where will you do it? A classical indication would be localized holding defects. Because if you have a horizontal bone loss, then you just do non-surgical. You don't need to do anything. It's only the angular bone loss patterns that you would see. Create a form of defects, only those ones, or require a regenerative surgery. Secondly, how would you identify? Take a probe and check. That's the best way to check. Third, one of the most foolproof ways to check whether the defect is angular or horizontal would be, apart from the IOPA, you can do is after multiple rounds of non-surgical therapy, you'll still see that if the defect is angular, you'll see the tissue has collapsed into the ditch, and that indicates that this site has got an angular defect. Results. What are the results with regenerative surgery? Now you can see, you can make it out for yourself through these cases that you saw. Results are absolutely predictable. Okay. If you follow the principles, yes, you can achieve outstanding outcomes. What is the percentage of growth? You will see 50%. Okay. So if you have a 8 mm defect, you will fill 4 mm, and that 4 mm fill is excellent enough to hold the tooth in the mouth for a very long period of time. Materials. When I started out, we hardly had materials. Now, literally every material under the sun is available in India. So you're actually at a much wider degree of freedom and creativity now. Economically, absolutely viable. Okay. Why do I mean by monetizably or economically viable? Two reasons. Number one is that these patients who come to you with these kind of defects, okay, they come to you knowing that they have a certain problem. They are highly aware patients. Most of all these patients, what you saw here in this presentation, were educated in the sense I told them what is their problem. I sat with them. I discussed with them what is the problem and what are the various treatment modalities available. Okay, and once you educate them well, okay, it is not what degrees they have, it is education in the sense of they are educated in the disease process and the treatment options available. Once they know this, they will understand that yes, what they are paying is worth every single penny, okay, of retaining the tooth. Please understand, okay, when you lose a tooth, you have an option to replace with an implant. Okay. When you lose an implant, it's not always possible that you can actually place one more implant. Okay. So understand that an implant is not a solution for a tooth that can be saved. A tooth that can be saved either by restorative means or by periodontal therapy or surgery means has to be saved. Okay. And when you save this tooth, for example, there's a patient with an angular bone loss, I treat it. That tooth lasts for the next 10 years. Okay. After 10 years, for some reason, the tooth is not becoming stable in the mouth. You can always take and put an implant in there. So you're making money twice over. You made money over the first round of non-surgical therapy, then you made money over the surgical therapy, and now you're making money over what you call placing an implant. Okay. And we all know that most of us practice in the same area. Most of these patients have a huge amount of trust in us. Okay. So when you build that trust, they are going to come back to you. So you're not going to lose money when you do regenerative therapy. You actually make more money out of it. Okay. So economically, regenerative periodontal therapy is highly viable. Okay. This is a question I always tell, and I keep on telling this. This is a point I always say. Isn't it prudent to knock off most of the teeth what you saw in the presentation and get an implant? The answer is this. A natural tooth with 50% bone will survive. Okay, we all know some of the teeth with so much of destruction will still survive and survive asymptomatically because they're natural. And anything that's natural has an inherent ability to survive than something that's artificial. Now, on the other hand, imagine I put a 10 long implant and then I start seeing 2 bone loss at the end of 2 years. What is the predictability that that implant would last the next 5 years? I'm not sure. Okay. On the other hand, I have a 2 to 50% bone loss. I've regenerated by 3 more millimeters. So I now have 8 bone. I'm pretty sure it lasts for the next 10 years. Okay. So understand a natural tooth has much higher degree of survivability than an implant. The next question is the age of entry of the patient into the treatment. If you saw those kind of horrendous bone loss in a patient, someone who's 65, 70, okay, you can knock off everything and put an implant, no issues. I will still do that. But on the other hand, if you see that kind of a bone loss in someone who's 25, 30, 40, okay, then I don't think they're candidates for implants. They're candidates to retain those teeth at least till the age of 40, 50, and then you start looking at putting an implant in there. Secondly, if someone has lost a tooth with so much of bone loss, and it also means that they can also lose bone around the implants. Periopathogens will repopulate even after total extraction and full mouth disinfection. Periopathogens repopulate a patient even after an implant. So, would I risk an implant with bone loss? I don't think so. So that's why save a natural tooth. Teeth live longer than you think. Okay, and that's why probably this is probably the most appropriate concluding slide I could put. The image that you see on the left is me trying to hold on the Tower of Pisa. Okay, that's what I would say. We do it to every tooth that comes, which I think we can save. Okay, and what you see on the other side is a tool with which we excavate the mud underneath and then reinforce it with concrete and other materials. So we have tools now, and only thing that would probably require is a bit of will on your side and education to the patient. And I think you can go ahead and save every tooth which with an appropriate form of regenerative therapy. And yes, you can make money with it. There's no doubt about it. And that's why regenerative pronounced therapy, surgery and therapy works and works for the good of you and works for the good for your patient. With this, I conclude my presentation, and now we will start taking questions.
Wonderful.
Ajit,
Absolutely wonderful. It was a great presentation, Sudhindra. You made such
hello,
a. Yeah, can you hear me? Can you hear
hello,
me? Can you hear me? Can you hear
hello.
me? Sudhindra, am I audible to
Yes,
you?
yes, yes,
Okay. So that was a great
yes, yes.
presentation.
I can hear you. Yes,
Yeah, yeah, yeah.
yes, Ajit. Thank you.
Yeah. So you made such a critical what you can say was such an important comment. Saving a tooth is much more important than just going for an implant. I remember Euro period 2007-8. I don't know which was that, where it was told that under similar
Yes,
conditions, teeth perform better than implants. And given similar
yes,
conditions, it's easier to maintain teeth than maintaining implants. So you made that,
absolutely.
and I remember when we finished Perio MDS, we used to discuss when people used to talk about full mouth bone grafting. We used to think, where do they put this bone graft? Where do they get so many defects? Because
Exactly.
we were we
Yes,
used to think about only those localized defects where we are so particular about inclusion, including only
yes,
those things. Otherwise, not going for grafts. And you covered all those points very in great detail. And I just made a few points that I want to tell.
yes,
You mentioned that you use EMD as a root biomodifier,
yes, yes.
and yeah, and it can generate cementum, something like acellular afibrillar cementum,
Hey, yes.
but acellular extensive fiber cementum is not possible. But even then, even AAC, if we get it, is going to be great.
Anytime.
Yeah. And one case that you showed endoperio, where everything got stabilized so well. How much do you attribute it to endo treatment?
See, there are two things. When the minute the lesion becomes an endoperio, I would want the endo to be sorted out for good, because in endo, you know what? If you look at the endo guys, also they always tell it's not the apical, it's the coronal seal that's more important. So if I have bacteria leaching from the top, then I'm in trouble. So I'd always want the top to be sealed off. The apex can be easily handled. If not, you can always chop it off and then put a graft there and build the apex. The issue is always with the coronal third. So that's why when I'm looking at any case with endopedio, I always see how good is a coronal seal than how good is a GP filling in there. Okay, so endo treatment has to be done because you have the canals, you have the communications, especially the furcation areas. I'm not worried much about the lateral canals or the apex. My primary concern is the furcation area. That's why
Got it.
endo has to be done. There's no this one about it.
And that ortho case was amazing. I think ortho perio is one of the
Yeah.
most underutilized and
Yes.
underexplored facet when it comes to treating intrabony
Yes.
defects. I think we should be utilizing it much more than what it is being done now. Uh,
Yes. Yes. But you'll be surprised, Rajiv. Actually, in my clinic, my orthodontist has more perio and restorative related ortho cases than actually straightforward ortho cases.
Amazing.
Because of the way we look at these things, we are saving teeth. We are bettering out dentitions. That's what I call it as.
And now that you are such an amazing implantologist, I just want to ask, in how many cases do you utilize orthodontic extraction, slow extrusion, then extraction to get the natural tissues?
No, that's one thing I have not tried. That's
Okay.
one thing you know what? Two reasons. Probably, maybe I've probably developed decent degree of skill to go grow the bone vertically. So I think I just go ahead and do that, because what happens with our orthodontists themselves are not very well versed with this slow extrusion, and the rate of extrusion is also not. I've done some probably two or three cases, but it's very tough, because what happens is you extrude, the tooth has to be trimmed. That
Yeah.
creates an aesthetic problem. You extrude, the tooth has to be trimmed. You extrude, the tooth has to be trimmed, and that's an issue. Okay. And patients wouldn't want to go around with one tooth which is well rounded and the other one which is getting chopped off at all corners. So that's an issue. So probably that's one reason why I have not made up my this one to do it. And also, what's
And
important is the biotype in what cases you do this. Not very easy.
yeah, true, 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 true. And I completely agree with your statement when you said you can anytime grow the bone vertically around an implant, but when it comes to growing getting the optimum regeneration around tooth, it's a different level of challenge.
Yes, because see, around when you have a edentulous ridge, you can pull the mucosa from anywhere. You can get a beautiful primary closure and seal it off completely. So your regenerative site can be completely walled off from all bacterial assaults. Okay, whereas when you have a defect, a small defect between two teeth with curved roots, developmental grooves, and everything, it's impossible for you to wall it off. You can
Yeah,
never seal it. It's only the body or the healing process should seal the long junctional epithelial attachment that seals against the root surface. That takes at least 10 to 12 days to form. So till that time, you have bacteria going into the defect, and that's why it's impossible to get 100% perio regeneration. If you get 50%, you're happy. I'm happy with it.
absolutely, absolutely. Uh, Let us start with a few audience questions. One of them says,
Yes.
which has been the regenerative material of choice of your treatment in recent times? And do you advise any special precautions in regenerative surgeries?
See, when I look at the bone graft, I would, if there is a source somewhere I can do a autogenous, I always still prefer an autogenous bone. You can use a scraper, you can use those very fine drills. Now, you have so many beautiful tools. You can do that. If not, you can use any bone graft under the sun. Okay, because what happens when you're looking at failure defects is we're looking at defect fill. I'm not looking at full bone turnover. That's never going to happen. Okay, and so whether I use a carbonate apatite, like what you call Regen ROS, Minros XP, or Matrix OS, whether you're using a BioOS or a ABM, or whether you're using fixed OS, or whether whatever material under the sun, or including no bone or what you call as bioactive glasses. When you use any of these materials, okay, the only thing is you have to pack them loosely. Don't pack them tight. In any period effect, pack them loose. Only autogenous bone has to be packed tightly, whereas every other material has to be packed loose. So you leave the room for the blood to fill in, you seal it off with a membrane, and that will do the job. And membrane, I've only used collagen membranes for perio surgeries. I've not used any other, so my experience on the rest is zero. I used PRF, yes, as primarily a growth factor area rather than anything else, or to enhance the clot interface, you can call it as nothing more than that.
Okay, okay.
Emdogain, yes, it's been 2 years now since I've been using Emdogain, and I'm pretty happy right now. It looks good. Only time will tell how things work in my hand. But world over, especially when you look at Cortellini, or when you look at Zucchelli, etc., when they do the root coverages, or when they treat these perio defects, their literature shows EMD having much wonderful outcomes. So I think that's an issue. I have to wait and watch now. I'll require 5 years, and I see
True.
these patients after 5 years. I can tell you whether it's worked or no. It's
Yes,
just as
yes.
simple as that. That's how perio disease is.
Agree. Totally agree. And I like that concept in some cases. Yeah, I wanted to ask, wherever closure is a problem and you don't want to bulk up the grafting material, where you don't want to add another membrane and you are just using PRF,
Yes,
what would be the
yes.
success rate? Because we are not, you are a hardcore membrane person. Even on blog graphs you have used
Yes,
membranes. And,
yes,
uh,
yes, yes. See, two things. One, fill only the graft only till the crest of the bone. Don't fill it more. That's number one. You put a PRF, and you know what? Now, for the last two cases, what I've actually done is the way we do a two-layer closure for a block graft. So actually, I'm releasing the flap much underneath. First, doing a periosteal to get a tension-free closure, and then a top closure. So what it is doing is when I'm doing a deeper closure first, okay, and then I take the epithelium up. I'm delaying the epithelium from down migrating. So that itself is helping me in what you call lowering the rate of epithelial down migration. So probably you can do away with a conventional GTI membrane and do with a PRF, which acts as a clot stabilizer itself. Clot acting as a clot stabilizer, literally like that.
okay, okay, okay. Great. I think we have covered almost all the question. All questions are done.
Okay, great.
So thank you, everybody. Thank you for joining in. There is one more question that has
Thank
come.
you.
Please share your point of view about laser assisted regeneration.
Uh, I have not used lasers. That's my always thing. And I don't want to make a comment on something that I've not used. It's just as simple as that. You can ask me anything on what I've used, I'll tell you in and out of it. Laser is something what I've not used. So I can probably, I won't be the right guy, I can tell you. I'm not the right guy to comment on that point. That's how I would look at it. I don't think I would be right because my answers may be biased. They can be for or against, but they may not be the right answers. So that's not my this one.
Maybe
If
maybe
it
we'll ask.
worked, it should work.
Uh, agree, agree. Okay. So that was for this evening. Thank you, Dr. Sudhindra Kulkarni, for accepting our invitation and being a speaker for this evening. It was an amazing session. It was an eye opener where so beautifully,
Thank you,
with
Ajay.
evidence base, you showed your clinical experience, and we have all learned a lot. And thank you, everybody. Thank you for joining in. I'm sure you have all got a lot to take home and apply in your clinical practice. Soon we'll be sending you a 5 point summary of this lecture along with a link to the recorded lecture for those who missed watching this lecture live. And that brings us to the end of 20th episode and to the end of 2022. Soon we'll be coming up with new topics in the year 2023. With this, We'll end this session of ICPA clinical series. The theme is each episode one clinical challenge. And I once again thank Dr. Sudhindra Kulkarni for enlightening us with his great clinical experience. Thank you, Sudhindra. Thank you so much.
Thank you. Thank you, Rajiv, and thanks to everyone, and wish you all a very happy 2023. Hopefully, China doesn't affect our COVIDs anymore. That's the only thing.
Happy New
Thank you
Year to
so
all
much.
of you. Happy New Year.
Thank you. Thank you. Yes,
Yeah.
thank you. Happy New Year to everyone.